This is The Common Health from the CSIS Bipartisan Alliance for Global Health Security, engaging senior leaders on questions of how to address our common health security challenges in this post-COVID moment. I'm delighted again to be joined by Apoorva Mandavilli today for this episode of The Common Health. Welcome, Apoorva, and thanks so much for making time with us. You've been extraordinarily busy of late, kind of ringside to several major things that we're going to talk about. So thank you for joining us.
Thanks for having me. It's my pleasure to be here again.
Apoorva is a science and global health reporter at the New York Times, came to the United States age 17 from southern India, did her college degree in the Midwest, Augustana College, master's in biochemistry at the University of Wisconsin-Madison, which is where I did my PhD in political science. Did a master's in journalism at NYU, worked in a number of places, came to the New York Times in, I think it was 2020.
That's right. I came to write about the pandemic.
To write about the pandemic, shared in the Times 2021 Pulitzer Prize for public service for coverage of the pandemic. Congratulations on that. Won the 2019 Victor Cohn Prize for excellence in medical science reporting. And interesting and relevant to this conversation, you were founding editor-in-chief of Spectrum, an award-winning news site on autism science. So you bring all of this background to this work now. We're going to talk about 4 topics that are hot where you have been writing very actively. Let's start with the fate of PEPFAR. It looks to me, with all of these things that have happened, a stop work order, a partial waiver, a vague and somewhat loose partial waiver, the whipsaw, the broader stoppage on foreign aid that covers all sorts of other health things, and some of the other problems that PEPFAR's had in terms of the reauthorization, the allegations of abortions committed, then this revelation just before the end of the Biden administration that, in fact, in a remote area of Zambezia in Mozambique, there had been 21 abortions carried out legally by Mozambican nurses that were on the payroll of the PEPFAR program, so in defiance. And so that caused a big stir. Things are a bit perilous right now, and people are really worried that this flagship program, dating back to 2003, that saved the lives of 25 million people, that has 20 million on therapy, that's saved 5.5 million children from becoming infected, may really be on the block. So tell us, what's going on with PEPFAR? You've been following this really closely. Should we be worried?
Yes, I do think actually that we should be worried because, as you mentioned, PEPFAR was already on the chopping block and was already facing some resistance from Republican congressmen and senators, in part because of this connection to abortion. But, I do want to note that those were just a couple of nurses in Mozambique, and PEPFAR employs 200,000 people. So it's a very small number that went wrong somewhere. But yes, so it was having trouble getting reauthorized. There was a lot of resistance. So it wasn't entirely a surprise that it was one of the first things that seemed to get put on hold. However, as you pointed out, it is responsible for treating a lot of people. And so I think when that fact sort of started to surface, it seemed like it became a part of this conversation about, humanitarian assistance and life-saving assistance. And so when Secretary of State Marco Rubio issued a sort of waiver for life-saving humanitarian assistance that included medicines, people in PEPFAR hoped and assumed that that would include the HIV medications. But I say hoped and assumed because even though that is what it would seem, there hasn't actually been a follow-up clarification saying, yes, it does apply to HIV medications. People have been waiting for that clarity. They've been waiting since Tuesday when the waiver was issued, but there's really been no development. Every day I hear, it's coming today, but no one has seen anything. And so in the absence of that clarity, people are really afraid to do anything. I think people are afraid to give out the medications. And so a bunch of clinics that I've talked to, a bunch of programs that I've talked to, they are really reluctant to move forward and act as if medication is okay to be distributed. And as you can imagine, that has huge repercussions for all the people who need those medicines.
And this stretches across, there are 13 core countries, but there are many other countries. As you know, every day there's 220,000 people receiving medications who are now on hold. That's just an extraordinary number. Two questions on this. One is, do you think PEPFAR is in the barrel because it fits some of the key themes that have been introduced now in this campaign of vengeance and retribution by the Trump administration? What I mean by that is it thought to be a DEI experiment in the sense of the populations served because it focuses on marginalized people. It focuses on men having sex with men. It focuses on sex workers. It focuses on populations that are oftentimes quite marginalized, stigmatized, and that raises a question. Is there some impulse underlying this in terms of retribution against Fauci? Because Fauci played such a pioneering role in conceptualizing this and advocating for it and proving that it could work. Then, of course, there's the abortion issue that's lurked out there and has been used erroneously to make allegations that, in fact, this program is systematically doing that, but when there's no proof. There's just been these accidental and very tiny aberrant cases. Tell me, what do you think?
Well, I hesitate to speculate exactly what is behind it. I do think that the abortion thing is a bit of a distraction. It could be that part of it is DEI because, as you pointed out, these programs do serve marginalized populations. And, we are actually hearing that at the CDC today, on Friday, they are actually deleting pages that have words like transgender and sex worker and prostitute and things like that. So definitely it could be part of that. But also I think it is part of this idea of America first, and we should be spending money on ourselves first and not having to pay money for other countries to treat their citizens. And, to be honest with you, that's not a new idea, right? There are people who have argued that these countries should pay for their own HIV medications, especially because now ARVs are a lot cheaper than they used to be. But that's something that needs to be really thought out carefully. And, there needs to be a handoff where people on the ground are trained and then PEPFAR slowly withdraws rather than this abrupt, okay, now you're done and you can no longer get anything.
We've known for some time that there are calls and the calls for reform are going to intensify, that there was going to be increased pressure to say, okay, what is the end game? What is the graduation strategy? What is the strategy by which national government partners assume greater ownership for this program? It can't be in perpetuity. But my sense is that while that rhetorically has been more common and people have been willing to agree to that very little has happened to put in place those kind of concrete reform measures. And then indeed, we lost quite a bit of time in these last few years in not having ready that. What are your thoughts?
I think that's true that we have not made as much progress towards having these countries be as independent as, everybody would like them to be. But that's not true across the board. I mean, South Africa relies very little now on PEPFAR aid, and that's true of some other countries. I do think that there hasn't been sort of a consistent change in how this is done across, for example, the continent of Africa. And yeah, I mean, maybe we did lose some ground, but I think we also lost some ground because of COVID. Some of these governments were really struck hard by all these other crises. There were delays in childhood vaccinations. There were so many other things to bring back up to speed that I don't think shifting things from PEPFAR support was sort of top of mind for a lot of these health ministries. Some countries are still battling polio, for example. There are some very urgent things going on in some of the countries that are reliant on PEPFAR.
Yeah, I would add to that one of the outcomes of COVID was a dramatic increase in the debt load that countries bore as a result of this for a variety of reasons, responsibilities that they assumed, change in the marketplace, inflation and the like, so that their fiscal position deteriorated quite a bit in this period. So the idea of, okay, now's the time to make a transition. The other thing is that PEPFAR made some serious attempts to turn its assets towards health security purposes in this period to support communities in responding to the threat that COVID posed and received some deserved credit for that. It didn't translate into a deepening of support here in the United States. What's happened here in the United States is it's become an aged priority. The generation that brought it in is retiring. It's competing against a whole bunch of other things. The bipartisanship that's been so foundational has eroded, and so it's become much more vulnerable to these sorts of angles of attack in this period, and COVID made that worse.
I think that's true. But, the bipartisan part is very interesting because it did used to be much more bipartisan, the support. And I don't think that's entirely gone away. I mean, Marco Rubio has actually always been a huge supporter of
Yes.
PEPFAR. And Dave Weldon, who is the nominee to lead the CDC, he was one of the Republican congressmen who actually co-sponsored PEPFAR. So it has had some very strong Republican support. I'm just not sure that that's translated to the current
No,
time.
I didn't mean to suggest that bipartisan is dead. Support is dead or has vanished. My point is that it's much weaker than it was. The mobilization of the faith community is much weaker. We did see when the work stoppage was applied across the board and affected PEPFAR late last week, there was, great objections raised, and it was Senators Lindsey Graham and Coons, Democratic Senator Coons from Delaware, and Senator Risch, chairman of the Senate Foreign Relations Committee, who intervened with Rubio to appeal to him to provide a waiver. And so it was a bipartisan appeal. So that's very important. Now, it didn't result in a very great clarification of exactly what was going on. Let's focus here for a moment. You've done a lot of writing on what the consequences of disruption are. What happens when 220,000 people a day are disrupted in their access to medications? You enumerate 4 or 5 areas in which we need to keep in mind when this program gets disrupted. 4 or 5 bad things start happening. You want to walk us through that?
Sure. So almost immediately, the amount of the ARVs that are already in your system start to go down. There's still a little bit of drug left when you stop taking them, but within a few days, that starts to be too little to really keep HIV in check. And so then the virus is always looking for that opportunity, and it comes roaring back. It starts to really affect the health. It starts to kill the CD4 immune cells, which are really its sort of main target. And that makes people vulnerable to all kinds of other infections. And this process, by the way, tends to happen really pretty fast in children. And that 200,000 you mentioned before, several thousand of those, about 7,000 are children who come in to get that treatment every day. And then, longer term, you start to see something that looks very much like AIDS, like we used to see here in the 80s and even, early 90s. The virus takes over your system and makes it impossible for you to withstand any infection, and then you are just vulnerable.
How quickly does that happen, Apoorva?
That can happen within a year, a couple of years. Hopefully, if people have some amount of health beforehand, it can last a little bit longer, but it really depends on the health of the person already. And of course, in a lot of the places that people are reliant on PEPFAR, they're not in the best of health to begin with.
So we have the disruption of medicines. We have the disruption of testing. What happens when testing is disrupted?
Well, you don't know who needs to be treated. And this can have really big implications. For example, when a pregnant woman may have HIV, no testing, you don't know that she's infected. You don't know that she needs treatment. And so she doesn't get treated. And then her baby, when it's born, has HIV. And then that baby's not tested. And now you've got a baby that has HIV that is very rapidly going to progress, through all those steps I just mentioned. So this has a lot of ramifications.
Now, you disrupt treatment. You're also going to invite resistance. What form does that take?
So HIV loves when there's just a little bit of drug around, like there would be if people stopped taking the drug, or they started maybe alternating days on which they're taking it or sharing it with other people. So when the virus sees only a little bit of drug, it sort of is smart enough to figure out, okay, this is what I need to get around. And that's how resistance emerges. And once resistance emerges and people start passing it on to others, which they will when the virus levels go up, that can take off. It can go all over the world, including coming to America.
Yeah. Now, when Omicron appeared, there was speculation that it may have arisen in immunocompromised populations that were living with HIV and were not receiving adequate therapy, and that provided the mixing environment, the environment in which this could happen. Are we going to see more of that potentially? In other words, where other biothreats emerge in the systems of these immunocompromised. You have a population of 20 million people who are being sustained on these therapies, a huge population. You put that into question, you're going to have a lot of immunocompromised people out there.
Yeah, what happens is when you have somebody who's immunocompromised and they get infected with something like the coronavirus, it takes them a really long time to clear that infection. And so the virus has a lot of time in that individual to play with all the possibilities of mutations. And so when we saw Omicron, for example, it had dozens of mutations that were different than anything we had seen before. It was a hugely different virus. It wasn't like the usual thing where, you see one version of a virus and then the next one is slightly different. It was very different. And that's why, it's thought that it evolved in somebody who had been infected for a very long time. It's true of some other coronavirus variants as well. So yeah, that's basically what we're looking at is we have this immunocompromised population that can play host to a wide variety of pathogens. And we're not entirely sure what would happen if people were to take those pathogens in, what would come out and what would end up circulating everywhere.
Last point about PEPFAR created a backbone, a global backbone on which science could be built, on which clinical trials could be carried out. Give us some examples. What's the value of having this backbone for clinical trials, and what happens if it goes away?
You may have seen headlines a few months ago where people said, you can take a pill once every 6 months and you're good to go with HIV prevention. Well, those trials were done in South Africa, and they were done with PEPFAR money. There were other things that are related to HIV that were done with PEPFAR money, like, women who can breastfeed when they have HIV, as long as they take certain medications, when it's safe, when it's not. All of those things that we benefited from, that information has come from the infrastructure that PEPFAR built. You also mentioned earlier, that during COVID, the PEPFAR infrastructure was used for COVID. And that's because it is so widespread. It's a very well-established system. So when you take that away, it doesn't just affect PEPFAR. It doesn't just affect HIV. It affects things like TB also. That infrastructure has really helped so many other things on the ground. And so the effects are really far-ranging.
Thank you. Let's shift to this week's dramatic hearings in the Finance Committee and the HELP Committee, Health, Education, Labor, and Pensions Committee, for RFK Jr., Robert F. Kennedy Jr., the nominee to be the Secretary of Health, Human Services Department. This was a dramatic, at times circus-like, relatively inconclusive in terms of it didn't really definitively lead anyone to the conclusion that he's a sure bet to get through the Senate and take up office, or he's a sure bet to be turned down. And it also revealed all sorts of fissures between Democrats and Republicans, internally between Republicans, and also revealing the power of things like the Maha movement. I mean, it was a fascinating 2 days. You were there ringside, and you and Cheryl Gay Stolberg and others writing really brilliant insights into what. So give us the big picture. Like when you're sitting around late at night on a Friday here or in the afternoon musing on what the hell was that? How do you make sense of this?
Yeah, there's no sitting around these days. But yes, when I think about that, I mean, I was expecting it to be, dramatic, but I was not expecting the level of fireworks. I mean, you had, Senator Maggie Hassan talking about her adult son with cerebral palsy and, in tears. You had Bill Cassidy and Rand Paul, two doctors really kind of disagreeing and arguing with each other about the safety of, and you had Bernie Sanders and RFK Jr. yelling at each other, literally. And it was just so much going on. For me, the main takeaway really was that RFK Jr. was sort of damned by his own history of many, many, many comments he's made about the safety of vaccines. I mean, he essentially said there is no vaccine that is safe and effective. He said tons of things about their connection to autism. And so I think that really haunted him. And you could see that when Senator Hassan said, we all here, meaning Democrats, really care about this answer. So this implication that somehow he was going to come in and set the record straight and that everybody else was lying, I think they really took some offense to that they didn't care about the answers. And you could see in particular also that Senator Cassidy was quite unhappy. I mean, he seemed to me like somebody who very much wanted to say yes. He wanted to vote yes. And he kept trying to lead RFK Jr. to say vaccines don't cause autism. But right. He refused. He never said that. There. Yeah, exactly. And so it's unclear what would happen there. I mean, he may still vote yes. I think he said, I'm going to reach out to you this weekend, or I may reach out to you this weekend. So maybe that will still happen. But it was not as clear cut as you might expect in terms of partisan lines. It was definitely for some people, but there were surprises.
Why was day 2 so much more dramatic and fiery than day 1?
Bernie Sanders? I think there were some some real characters. And also, I think, Bill Cassidy, I think he came in thinking, I really want some answers. So he was pushing hard because I think he's really trying very hard to figure out which way he's going to vote. And that intensity also pushed things, although he did it in the most calm, polite manner. He definitely wanted answers. And I think all of that just, altogether really raises the stakes.
I was struck by the divisions that you had Senators Paul, Mullen, and Tuberville siding with the skepticism of vaccines, siding with the autism arguments. You had Cassidy openly saying, wait a second, that is just not. And then you had the debate over the merits of hepatitis B vaccines for newborns. Lots of science there. Then you have, it was kind of like you had this division in American society right in front of your eyes in the division among the Republicans on this committee.
To me, the interesting thing was also that you could see the division in how people think about science. Because, the senators that you mentioned, they brought up things like, well, all he's trying to do is ask questions. We should be applauding him. But then you had the doctor, Cassidy, saying, look, this is already all settled. What do you mean? We need to look at the science. The science is there, and this is what the science has said. So this is not just about asking. This is, you're just reopening things, relitigating things that have been very well settled. And so I think that idea that somehow this is admirable, he's asking questions because we don't know yet what is going on. I think that's the real divide there. One side saying we still don't know, and the other side saying, well, we don't know what causes autism exactly, but we know there are all these other things that are contributing to it, and we do know that vaccines are not one of them.
His thesis, RFK's strategy was to try to put on the lower back shelf, the vaccine stuff, and concentrate the conversation around dealing with chronic diseases, prevention, healthier foods, pushback on industry. That didn't really work here, right? They got into a contestation where Sanders said a couple of things, but basically Sanders never came over to say, oh, this other agenda is one where we can really sit and work closely with you. They never got to that point. They never got out of the, wait a second. His history of falsehoods just kept rolling forward step by step by step by step. It was relentless.
And that was really interesting because, before the hearings, there was some speculation that Bernie Sanders might actually vote yes because they have that in common. But I think the concern over vaccines really was just the overriding theme throughout. And I don't know how much of that is because of some very real efforts by a lot of different groups, including a lot of academic experts who have worked very hard to talk about these issues. The Health Committee, Bernie Sanders hosted that entire briefing with 4 experts on vaccine science and epidemiology to have them come in and talk. And so I think that has really been the primary thing everybody has been worried about.
Okay. Withdrawal from WHO. You've done some very careful thinking about how this is going to hurt Americans. Let's walk through that. What's the argument for why this is bad decision for the health and well-being of Americans?
Okay, well, let's do the obvious one first. Global health security, emerging outbreaks. We've got Marburg in Tanzania right now. There's another Ebola outbreak that is starting in Uganda. And there are, all these efforts that the WHO does to stay on top of things like that, including polio and measles and things that we've been fighting for years. So we need information about those things, Mpox, for example. But then there are all these other things that people don't even realize the WHO does. So, for example, the system of diagnostic codes that we use in this country, it's called ICD. It's one that every doctor, every insurer uses. That is put together by the WHO along with its member countries. The WHO also comes up, again, with its member countries for chemical names of all of these drugs. Like if, you might take something that is an antibiotic like doxycycline or amoxicillin, but it might be marketed under different brand names in different places. And the way that it is recognizable all over the world is by those chemical names. And that's something that the WHO does. And those things have implications for, American businesses too. They can do what they need to do in these countries, whether it's because of an emerging disease or whether it's because of these chemical names or whatever it is, because of the work that the WHO is doing. And then one thing that the WHO does every year that I think people may not realize is it has a massive network of flu surveillance. And so we find out in the spring every year what flu strains are circulating. The WHO convenes its experts and they decide, okay, this is the best flu vaccine for this coming fall season. And that's what we end up taking here in this country. So now if we're not a member of the WHO, we might still be able to freeload a little bit and get some information, but we have zero input into any of these things that the WHO does. We will just be people standing on the sideline with our nose pressed against the glass, hoping for some information.
What happens there's a number of different products, technologies that American industry has brought forward that are diagnostics, that are vaccines, that are therapies, that are other medical devices that are going through a process of pre-qualification where it needs to be concluded and there needs to be cooperation and communication between WHO and FDA. What happens now when you've got over 35 products that are in the mix right now that have been developed by American industry, which are thought to be credible and contribute to the well-being of the world, and they need to make that passage through the pre-qualifying process with WHO, but there's now a decision taken that our agencies, our health and regulatory agencies, are not to communicate with WHO. So what happens?
Yeah, it's unclear what happens. These companies are actually really reliant on the WHO's pre-authorizations because a lot of countries don't have their own FDA. So they rely on the WHO to evaluate drugs and say, okay, this one is okay for use. And that system is so well entrenched that global health organizations won't even release money to health ministries to purchase something unless the WHO has already authorized it. And so you've got all these companies that really need the WHO to sign off on their products. And if they can't talk to the FDA, if these companies can't work with US regulatory agencies to talk to them, they don't really have a seat at the table to say, these are the standards that we should be looking at for this particular thing. They're just left out of the process. And that may have very real consequences for pharmaceutical companies, health technology companies, device makers, all kinds of American businesses.
Thank you. Last topic is H5N1, the bird flu. You've been working on this since 2003, as I recall, and you've done some great reporting on this, going back to its East Asia roots, to the spread to U.S. wild aquatic birds in 2022, and the sort of explosion of this virus into all sorts of other animal species. And now we've got, dating back to early last year, you're reporting on the entry into the American dairy herds. You're sounding the alarm saying that we need to recognize that we've entered, a couple of things have happened that signal that we've entered a new phase that's more dangerous than what we were in before. Can you explain?
Yeah, several things have happened in the last 2 to 3 months that have really, I think, changed the experts I talked to, their perception of where we are in this. If you think about it as a sort of path to a pandemic, we've really moved much further along. So one thing that happened is we've had a death of a person in Louisiana. And there was another one, a young woman in Canada who was hospitalized and was very, very ill. She survived, thankfully. But both of those came from a new version of H5N1 that has just recently started circulating, and it's now everywhere in wild birds. And that is separate from the one that's been circulating in cows, which also at some point came from wild birds. But now you've got two versions of H5N1, and they're both everywhere. So you just have all of these new opportunities for the virus to jump into people. We have 67 cases now, and the number really sort of shot up over the last 6 months. And we've had California, which is a huge part of our dairy industry, and that's been really hard hit. And I've heard from other states that they also actually had similar problems, that they were really actually very hit very badly, but they just didn't want to be as open as California.
And you were suggesting that some of the data coming out of like Idaho suggests that herds are becoming reinfected, which suggests that the virus is circulating in an endemic fashion. Why is that dangerous and important?
Yeah, I mean, I think that the states not being open, that's a very direct problem to this reinfection issue, because the states don't want to talk about what's going on. And so we have not known whether the herds that were first infected, how long it took them to clear the infection, whether they've ever been reinfected, what does that look like? None of that. And so I was able to find out about Idaho, there were actually some herds in Idaho that got reinfected in November for a second time. They'd been infected for the first time in the spring. And that means that you can have cows get infected over and over again. And the really troubling thing about that, maybe not for the farm owners, but for us, is that the second time around, some of these cows showed very mild symptoms. So you may not even realize that those cows are infected. And if you don't realize, you're not keeping an eye on them, you don't know what's going on, people can't take protections around them. It just creates this really big problem in terms of detection, but it also suggests that we might now be stuck with this virus circulating in cattle forever. And that means forever we're going to have this issue of it may jump from a cow to a dairy worker and then take off from there.
Now, you've said that one of the deeper problems here is just the response itself in terms of testing, outreach to herds, workers, protective gear, very weak guidelines, delays in releasing data, a kind of sluggish and complacent response. Say a bit about that.
Some of this is inherent to our system where the federal government actually does not have that much authority on what goes on in states. And so we have not had mandated testing, for example. When there's a farm that's affected, there's no mandated testing of the cows or of the people who work with them. We just in December started testing bulk milk as a mandatory activity to see what, which herds might be infected. But some states were doing that on their own. But, federally, nothing was being done really that was mandatory. And I think some of that is a hangover from the COVID pandemic where they don't want to talk about anything that's mandatory. So every time, for example, in all the press briefings, they were very careful to say, we're not making anyone do anything, as if that were a good thing. But that also meant, people weren't necessarily wearing PPE. The farm workers that were really at high risk were not wearing protective equipment, and a good number of the infections were in people who were either farm or poultry workers. And so we've left all these gaps in surveillance in terms of testing, in protecting people, so preventing the disease, and in figuring out what exactly is going on, because we have very little epidemiological information on who got infected, how long they were infected, what the proportion of people who actually had severe symptoms is versus the number of people who got infected. We know very little, actually, about how this outbreak has gone.
Thank you. One last question on this. The Biden administration, right before it ended, introduced a measure for a $306 million contribution. About a third of that was testing and support to the states in improving their surveillance and their outreach and their ability to support workers and the like. What's happened to that $306 million? Did that actually happen, or has it gotten caught up in some of the EO measures that have sort of disrupted disbursement or movement forward?
At least some of it has gotten stuck. We know that the federal freeze in theory has been reversed, but a lot of places they're still not really able to access payments. And I've talked to farm worker organizations that get sort of trickle-down funding from the federal government to states to them, and they have not been able to draw any funding either. And so we don't really know what the fate of that money is at the moment.
Okay. Last question we ask all of our esteemed guests, what gives you hope? What gives you optimism here? You've been at the front lines of some pretty complicated, fast-breaking stuff, so leave us on a good note here today, Apoorva.
Well, I found out today that there were a lot of scientists who were coming together for a data-thon to try and save websites that they thought were important to public health and health equity and all of those kinds of issues. So that was actually quite interesting and inspiring to hear about all of these scientists in very different disciplines, all interested in this core issue of public health and health equity, coming together to do something that they thought was important. I found this cooperative effort to be very inspiring.
Thank you. That's a great answer. And thank you for taking the time. I know you're still very, very busy today, and keep up the great work. And thanks for your generosity with us today.
Thank you. It's my pleasure.
Thank you for listening to The Common Health. If you enjoyed this podcast, please give us a follow and leave a review. To learn more about the CSIS Bipartisan Alliance for Global Health Security or listen to other CSIS podcasts, please visit csis.org.